Good morning, everyone. This is Dr. Sandeep. I'm a fellow from Daradia. Today, I will be discussing the MRI of lumbar spine, starting from very basics of MRI principles, moving through the relevant lumbar spine anatomy, and then systematically covering the common clinical important pathologies that a pain physician encounters in a day-to-day practice. Each MRI, there are certain things we have to know before going into the identifying the anatomy or pathology. First is the plane of the imaging. Sagittal, whether it's axial or coronal. Sagittal and axial are most important for the LS spine, and coronal is mostly used in the SI joint. And the sequence type T1, T2, or STR, we will see later, and how the CSF looks in this, and left and right orientation. Left and right orientation also it is most important. How we should imagine it's like imagine that you are standing at the foot end of the MRI and seeing a patient. So his left hand will be your right side and right hand will be your left side. So that is the reason the image left and right is reversed in an MRI. And the level identification, that is also most important. And others, we want to rule out all the red flags also, so that we can refer to the surgeons or for the further management. First, we will see how the different plane looks. Left side is the sagittal plane and right side is the axial plane, which we commonly use in the LS spine. And now we will come to the sequence, whether it's T1 or T2. T1, how we can identify is that fluid will be dark in T1 and fat will be white. So that is the as simple if you want to keep like this. CSF, as we can see, this dark, and epidural fat which is white, and the subcutaneous fat is also white. Here we can say. But in this patient, the subcutaneous fat is so huge, so it can be easily visible. If the subcutaneous fat is not there, then you should concentrate on the epidural fat. Epidural fat will also always be there in the patient, so that will become white. And next is the T2. T2, as we can see, the fluid is white. Fluid is white, and disc also will be a little bit brighter, and subcutaneous fat and epidural fat is also white. So this is the main difference between, if you want to see just and identify, just see the CSF. CSF is white means that is T2, CSF it is dark means it is T2. So the difference between T1 and T2 is, in T1, fluid will be black, fat will be white. In T2, both fluid and fat will be white. And this contains nucleus pulposus, so it will be bright. Next, again, another image is the STAR image. STAR image is nothing but T2 image with the fat suppressed. As you can see, the subcutaneous fat is suppressed and epidural fat is also suppressed. But the fluid is more whiter, and disc is also more brighter. And as we can see, the vertebral body is also got a little bit suppressed. That is because in MRI we don't see bone. We see only bone marrow. Bone marrow is mostly comprised of fat. So that is also get suppressed because of that. And disc is having the more nucleus pulposus and fluid is there. And this is another physiological change. As we can see, the small lines you can see everywhere. This is mostly present in many young patients. This is nothing but an fat deposition around the sinovertebral nerve and vessels. So that if we see this, we cannot, we don't think that as a pathological changes. See here also, this is the T2. Here also you can see. And now this identification, what I already told. Left side will be the right side will be the left. Now we will go into the each image. Each image, this is the true mid-sagittal view. How I am telling is a true mid-sagittal view. Here you can see the spinal canal diameter is maximum. In which view it is there? That is the true mid-sagittal. And you can see all the anatomical structures like vertebral body, disc, the spine is, and this thin layer at the back is the ligamentum flavum, which you can see. And there will be a thin layer here also, that is posterior longitudinal ligament. And we can also see the spinal cord around it. So mid-sagittal view, we can, the main thing what we are seeing is anatomy. You first identify, and then we want to see the disc, whether the disc is bulging out or there is an extrusion, sequestration, and all is there. Every image I will show. And the canal diameter also we can measure. Usually the canal diameter will be around 15 to 20 mm. If it is less than 10 or less than 12 itself, we will call this as a canal stenosis. And if it is going less than 8 and all, it is very emergency. You have to find the cause very quickly. And This is the next cut. This is the just next after lateral side, either right or left side of that. This is the parasagittal region. When how can you say this is a parasagittal region? As you can see, the spinal canal diameter is decreasing little bit, and this is not a foraminal cut also because we are not seeing the foramen. So this is the true sagittal between the true sagittal view and the foramen. Here we can see the traversing nerve root also, but this nerve root has not come out yet. It will go most usually the nerve root what it will do it from the posterior it will come anterior and inferior also and then come. So this is the in between cut where before it is getting exited. This is the parasagittal view. This is also most important because the in bulge and all there will be a central bulge and paracentral bulge also. Paracentral bulge can be nicely seen in this. And you can see the nerve root coming out also, whether it is pushing the nerve root backwards or not, that also we can see. Next, this is the example which I was showing. Here, this is the parasagittal view where the disc is bulging out and this pushing against the nerve traversing nerve root. So we can correlate whether if the pain is if the patient is having along the traversing nerve root pain, then you can correlate this image. Foraminal sagittal region. As we can see, this is the nice foramen where you can see the anterior border is formed by a vertebral body and the disc posterior border above and below is by pedicle, posteriorly is by superior articular facet and inferior articular facet, and you can see nice nerve root, exiting nerve root or dorsal ganglion will be fitting here, and this is beautifully visible because this is a foramen is filled by fat. So fat is glistening like anything in the background so that the nerve root is nicely seen. If there is any for a paracentral bulge or foraminal bulge which is compressing, you can see here. Here you can see all the foramens are nicely visible. But in this area, the foramen is not nicely visible. Here the disc is bulging out and compressing the foramen. So this is the foraminal bulge. The patient will have excruciating pain because the dorsal root ganglion is rotated over there, which is a house of all sensory fibers. So it will cause severe pain. This is a sagittal view where you can see the bulge is there, which is compressing the nerve roots, which is causing. And another main thing, but this can be asymptomatic also. Another main thing which you want to identify in this is disc. This disc is like glistening like anything when compared to other disc. This means the water in the disc has been dehydrated, and when compared to this, so this can be if you are not finding any other pathology for the pain generator, then we can consider this as a discogenic back pain. Now, let's come to the axial section. Axial section, when we see this axial cut into three parts. One is the anterior part where we see the entire disc, and the middle part where we see the canal and the foramen, and the posterior part where we will see the posterior arch. Posterior arch, remember this like a wishbone. So it is looking like a wishbone. You have to see any discontinuity or any pathology. Everything I will discuss. And the anatomical parts which is located in which place we want to see. So this is the L3 discal space, and this is, can you identify which sequences is T1, T2, or T2? See the canal, it is darker. So this is the only thing we want to see. See the canal, if it is black, T1, white, T2. Okay, and this is the anatomical structures. What we see, this superior articular facet, and this also you can see, this is a synovial joint. In T2 it will be white. This is blacker in T1. And this is inferior articular facet, and this is the pars interarticular, this is lamina, this is spinous process, and this V-shaped one is the ligamentum flavum, and this is the foramen. All these 7 to 8 parts are most important for us. We have to identify everything so that it will be different in each pathology, we can say. That is the same thing which is now the level identification. Level identification is the most important for us because if we identify in pathology, instead if we don't know which level we are, we cannot correlate that with the patients, because sometimes the L4 nerve root will be bulging, but the patient pain will be on the L5. So that MRI finding will become irrelevant. So we want to identify. One of the easy method to identify is that you want to take a first see from below. First see the sacral base and ala. That is usually easily everyone can find because this SI joint and all will be there. This you can see. Now go to one sequence above. First, if you go to one sequence above, here you can see the sacral ala also. You can see a small round thing which is popping out from the canal. If you go slowly above, it will be looking like a Mickey Mouse. Okay, so this is nothing but this is what we are going up after sacral ala. You will see the L5S1 disc. L5S1, if you go there, it is like L5 will be coming out, S1 will be a traversing. So this is nothing but traversing. Why this is more specific to this level means in other levels, this traversing nerve root will be inside the canal. Only in this level, the S1 nerve root will be outside the canal. So if you see this, you will be sure that sometimes it can be at the L4, L5 level also, but most of the patients, this is the view. In this view, if you see this is the S1 traversing nerve root, then you know that S1 traversing nerve root is at the L5 S1, then you can one level up, you can go and find. As you can see, this is the one. And here you can see clearly see the facet also. This is the disc cut. If you go slowly above, you can count like that. This is nothing but we are going up and up till the L3, L4 disc. Okay. So this is one of these are the basic things you want to know before you are going to identify the pathology. As we saw earlier, no, canal is like bright like anything. So this is T2. These are the structures of what I told. This is the S1 traversing nerve root, and inside you can see the other traversing again annotated measurement of the same. And now we will go into the algorithm. Algorithm, initially what I told, first we will see the anterior part. Anterior part is nothing but disc. Disc, you want to see the entire border of the disc, whether it is equal in every place, whether it is bulging out or any focal outpoaching is there. And you want to see this space here also. This neural foraminal space is there or not. Mostly the fat will be there, so it will be little bit glistening. So this gap you have to see. If the gap is not seen, then it is like there is something is coming and bulging. Now, first we will see about the disc bulge. Disc bulge is nothing but the entire disc is bulged throughout. And another thing you want to see that the spinal canal will be looking like a shield like. So it will be upper, it will be little bit this convexity will be there, and there should be a concavity in the disc. If it is changing, the shield like thing is getting obscured, then you can call it as disc bulge. And you have to see whether there is only focal outpoaching or entire disc is bulge. Here you can see the entire disc is bulge. It is not only here. Entire, like you can create a circle around this. So this is called disc bulge. But here, if you see, there is a focal outpoaching. So focal outpoaching, and the space is this side is normal, but this side it is getting obscure. So there is a focal outpoaching. There is a large lateral foraminal herniation has happened, and this is obscuring the exiting nerve. So this here you can see the spinal canal is dark, so it is T1 imaging. Next is the HIS. What is HIS? Hyperintense zone. High intense zone. High intense zone is nothing but this is an indication for annular tear has happened. So annular tear, when it is happening, then what our body will do? Our body will try to make it heal. How healing happens? Healing happens by vascular granulation tissue. Granulation tissue is very glistening in this. This is the sign of the HIS. So this is the sign of the annular tear. And here you can see a large annular tear bilaterally, but still the little bit bulge has happened, but the content of the disc is not leaked yet. So this is also one of the important sign in annular tear, where it is nothing but a HIS we are seeing in an axial cut. And here you can see there is a concentric annular tear. There is a concentric annular tear. Yesterday, last class, we were discussing about the types of the tear and all. The concentric annular tear will be like this. But this is the axial cut where we are taking a cut from this, so it is looking like that. Next, we have to see the neural foramina and thecal sac. This is the neural foraminal area. The most thing, any disc, bulge, protrusion, extrusion, everything will come and affect those parts. So we have to go in detail. What are the types of bulge, herniation, everything we have to see. Now, here you can see there is some central and paracentral bulge, which is happening, pushing the spinal canal down. And this thin layer which you are seeing, this can be the posterior longitudinal. That is also one of the important thing to identify. I will tell in next slides, subsequent slides. This is the thing. This is the thing which is exactly obscuring that exiting nerve root also and traversing nerve root inside the spinal canal also. This can and these are the types of the zones of the bulging where it can occur. This is the central zone, this is the paracentral zone, this is the foraminal zone, and this is the lateral zone. The each zone, when the bulge is happening, it is named after that. And here again, this is the image what we saw already. Here you can see the paracentral and lateral everywhere, the entire area the bulge is happening, and it is compressing the entirely obscuring the foramen and traversing and exiting nerve root also. This can obscure. Here you can see the nice central bulge. Bulge which is obscuring the canal. This you can see the mild to moderate canal stenosis based upon the patient's symptom. Patient will have the claudication. Here you can see the just next right side to right side of the patient. You can see the bulge, and here also you can see the focal outputting. This is called the mixed bulge or herniation. And now the types of the herniation. There are three types which everyone would have came across: protrusion, extrusion, and sequestration. The difference between the sequestration is quite clear. Sequestration is bulging out, and it is one separate part is hanging outside. So that is called sequestration. The difference between protrusion and extrusion is that in protrusion, as we can see, the outer structure or the annulus fibrosus or the posterior longitudinal ligament is still intact, so that the bulge is still inside the disc. It has not came out. Here this nucleus pulposus is breaking out the posterior longitudinal ligament or the annulus fibrosus, and it is coming out. That is the main difference between the protrusion and extrusion. You can see this thin layer, this can be the posterior longitudinal ligament. It is coming out of this, so you can call this as an extrusion. Disc bulge or protrusion or extrusion, which is more dangerous? More dangerous. Protrusion may there will be very mild only. Extrusion may there will be more severe. More amount of disc will be popping out. So which is more dangerous. In protrusion, what it occurs means the disc is entirely sealed from the epidural space. It is entirely sealed from the vessels which is present in the epidural space. So there is no chance of healing. But here the entire part is out to the world for the epidural space to heal it, and this phagocytosis will occur, and it get there is a chance of healing is there. So extrusion, if it is there, if there is no red flags are there, so there is chance of more healing. But since this is concealed inside, the pain also will be on chronic pain will be there, and the body's chance of healing is also very. This is the protrusion, as we can see. This is the posterior longitudinal ligament, and the disc is leaking out, but this still it is contained. You can see in the report also this contained disc bulge. Contained disc bulge is nothing but protrusion. This is the same thing, as you can see, this bulging. And in the they have mentioned also protrusion and extrusion difference. Protrusion base of the disc bulge. If you measure the base and the entire length of the bulge, both will be same in protrusion. In extrusion, the head of the bulge will be more bigger than the neck. So that is also one of the differences too. And next, here you can see the entire disc is coming out, and it is extrusion. This is the clear, the posterior layer is breached out and it is came out. So this is the extrusion. So this is the disc extrusion, what I was telling. Here you can see the torn off posterior longitudinal ligament, and the disc is bulging. And this is the mechanism which I was telling about. Here you can see the very large extrusion, and this is the 12-month follow-up of the patient. Here, as you can see, the entire extrusion has been recovered, and the patient. This is called sequestered fragment, which is came out. There is a separate fragment here and here. And next is the posterior arch. Posterior arch is nothing but facet, pars interarticularis, lamina, and spinous process. Everything will get including the posterior arch. We want to see whether there is any bracket and ligamentum flavum. Ligamentum flavum is most important. Here you can see the thin layer V-shaped ligamentum flavum. That will also can compress the canal. Here, that is the same anatomy of the central canal which we have discussed. and this is the exact disc cut. This is the one level below. If you see the boundaries of the canal, you can see in the lateral boundaries will be the pedicle, superior articular process, and the transverse process will also come. Mostly, initially, I also had some difficulty in the MRI. While in some cut, if I see, it will be looking like the disc is coming out. But those cut are like pedicles, and you can see the nice transverse process. So when you see the transverse process here, then that is a pedicle cut. You can anatomically clear this. This is not any disc bulge coming.
Also, the intensity of the body and pedicle.
Yeah, that also you can see the disc will be like outer will be black, inner will be the white because of the annulus fibrous and pulposus. And here you can see the MRI where the ligamentum flavum is thickened. Here the ligamentum flavum is also thickened and the disc is also bulging out. It is compressing the canal. So this is the reason for the canal stenosis. Here there is another image where there is a paracentral or lateral bulge, foraminal bulge you can see, and the ligamentum flavum is also thickened and it is causing. And any other finding are you saying in this? As you can see, the lamina is not continuous. There is a break in the lamina. This mostly you can see in the post-laminectomy patients. When they come, you can see this change. And this is the nothing but a canal stenosis where the explanation here they are given. The ligamentum flavum can be thickened and compress the sac, and the bulge can also compress the sac, causing the canal stenosis. And the sagittal cut is also very important for to know the how vigorous it is. As you can see the canal diameter where you can see, as you remember, initially I said the normal diameter will be around 15 to 20, but here it is very less. When it is less than 10 or less than 8 itself, we should be very cautious, and if there is any red flags, we should refer for the emergency surgical correction. And here you cannot see the canal itself. The bulging coming around the canal and ligamentum flavum is thickened so much, compressing this like a complete canal stenosis symptom. Patient will know. Next is the SI joint. SI joint, this is an X-ray image, AP image. SI joint, you can see in the it's useful to see any acute changes and chronic changes also. Here you can see the two joint lines is nicely visible, and there are no much sclerosis and erosion. This is how the normal looking SI joint. And in SI joint, if there is any sacroiliitis, there are total 4 gradings are there. These are the 4 gradings which I will say, and 4 gradings. Initially there will be a mild blurring of this joint line will be there, and mild sclerosis, not that much. These like this change, but joint will be pretty normal. Only the size of the joints will be visible. Here in the next grade 2 you will see there is some bit of erosions also you can see, and there is a significant sclerosis you can see, and the joint line is also very narrow, that you can see. And in grade 3, if you go in some places due to the joint erosion, you can see there will be widening of the space. That widening of the space is most important for the grade 3, and you can see the significant sclerosis. And some place you can see the joint is fused also, partial fused also. That is grade 3. And in grade 4, if you see the entire ankylosis has happened, and you cannot see the joint. This is the changes. No change, suspected change, minimal change, advanced change, and total ankylosis. These are the 4 grades. This is another same image. Here you can beautifully see the SI joint, which is almost S shape, and here it started eroding, and the erosion is more, and total fusion has occurred. This is the same CT imaging where we can reciprocate the same grading. As you can see here you can see the total fusion has occurred in the anterior part. Here, this is the place where the synovial membrane will be there. So now, the MRI features. MRI features, there are 2 changes are there. Initially, when the sacroiliitis occur, inflammation will occur. Inflammation will slowly occur for a long duration, then it will become structural changes. So we want to differentiate whether there is inflammatory changes or structural changes. Why means inflammatory structural changes can occur in other pathologies also. Inflammatory changes is any inflammatory arthritis like this ankylosing spondylitis or anything. And then how to differentiate whether it is acute change or chronic change, that for that also it is useful. Inflammatory changes, we will see marrow edema, synovitis or capsulitis, enthesitis we can see. And subchondral changes, all are bony changes. There will be a near joint, there will be a sclerosis, and there will be erosion. Backfill will be there. Backfill is nothing but when there is an erosion of the bone, fat will be there. It is like fat metaplasia only. So other thing is the ankylosing, entire fusion has occurred. In first image, subcutaneous fat is suppressed and disc is white, so it is STR. In the second image, we can see disc is black and subcutaneous fat is white, so it is. And so here you can see the image. There is clear edema is there in both the iliac and sacral bones. And next, this is then again the STR image. As you can see, the beautiful. These are both the same patient but different cuts. Here you can see the more. It is more brighter. It means more edema and more active is the lesion. But in other side, it is pretty normal. So it is on unilateral sacroiliitis. The first image, which is T1, where the fat is white and disc is black, and the second image is the STR. This is the significance of comparing between the STR and the T1 image. In STR, fluid is seen as white, and T1 image, fluid is seen as black. So when we compare that, we can clearly see there is an edema. Now tell me this, T1 or T2? Not stir, definitely. Now we will see the difference. This is the STR image where the fat is suppressed. So white thing which you are seeing is the epidural fat. So fat has been suppressed here. So this is not fluid. This is fat. So that is T1. You can see the disc and also tell, but provided that is not degenerate. Here another I wanted to show. Here it is white. Here comes the STR significance, but here it is black. So it has suppressed. So that is an fatty infiltration. So fatty infiltration of the subchondral bone. So that is fat metaplasia. This is the most I want to concentrate. Here, if you see any hyper intense lesion, you can see here the capsule also will be there. The capsule will be, if there is an edema or inflammation has occurred, that is called capsulitis. No, so capsulitis is also one of the acute changes. And here you can see the bone, subchondral bone is also very white. This is an STR image, so edema. That is edema, so it is a quite active disease. And next, this is the image where you can see the STR image. You can see the white lesion over here. So this is an edema. And here also you can see the other ligaments. These are the area where the ligaments is coming attached. So this is called enthesitis. So this is an image of enthesitis where that is also one of the acute changes of sacral. And here you can see the bone marrow edema is nicely seen. These are the multiple images I have added so that it will be more clearer. Here you can see, and a little bit of bony irregularities also you can see. That you can see this very white line and extending till here. So this is an active inflammation is there in the surrounding tissues also. There can be infection also, chances or risk is there, or enthesitis, everything is combined to. This is another image where you can see the image in the SI joint is so widened up. So here it is pretty okay, but here the sclerosis has occurred. This is almost grade 3, where the joint space is very large. And another thing you want to see, if you zoom here and see, there is a black area here. Okay, so the joint has ended here itself. This is the black area. This is maybe mostly the erosion, the sclerosis. Sclerosis has happened. That is why it is black. And there is another classification which I saw. Type A, the inflammation at the site of the erosion will be there. Type B, it will be mixed. Type C, there will be a fat metaplasia will be there. Based upon the T1 and the STIR, we can classify, we can differentiate between the types. This is the T1 STIR and CT image compared, and they are shown. This is a normal image, and in the type A, where there is an inflammation will be there. There will be inflammation at the site of erosion. So here the erosion has occurred, and the inflammation little bit when compared to here, it is hyper intense. So the inflammation has occurred. Here both inflammation and so here only inflammation has occurred. This will be mixed. So inflammation and fat will be there. Here As you can see, only fat will be there. Fat will be covering the this which is separated in the STA remain. So it is looking like normal. So this is the type 3. Next is the spondylolisthesis. Spondylolisthesis is nothing but the upper vertebral body has slipped and came forward of the lower vertebral body. This is if you want to tell in a simple terms. But mostly this arch, which is arch, this vertebral body is kept in place because of the posterior arch. When there is any damage to this posterior arch, as we can see, there is a damage. That is a pars intervertebral which got fractured, and because of this, the stability has been gone. So the L5 came out in front of the sacral base. And this is a normal looking spine. Here we can see this L1, this above T12, L2 and all, this is a little bit backward. But L3, L4, L5 is little bit forward. So because of the gravity, these three vertebral body is most common for listhesis. Because of the gravity, it can easily come forward and this listhesis can occur. These are the gradings where within 25 it's grade 1, 25 to 50 grade 2, 25 to 75 grade 3, near 100 is more than 75 is grade 4, and if it is completely then it is grade 5. And the CT, we can see the bony structures very nicely. We can see in the X-ray also, as we can see the pars interarticular is quite intact here. Here it is broken, and little bit 25 to 50% it came out in forward also. So this is the anterior listhesis. And again, as we can see, the integrity is, this is the edge you want to see. So here you see the break and little bit listhesis also. Again, the same image. Here you can see the break, and the it is almost like 25 to 50, so it is grade 2. This again is the same, as you can see the fracture, and it is. I have added multiple images so that it will be stick to in our mind. And another thing is that degenerative spondylolisthesis. What is the difference? Is means in degenerative the posterior arch will be intact, but there will be some listhesis. So this is called a degenerative spondylolisthesis, where there is no structural damage, but still the listhesis has occurred. You can see in the MRI also, degenerative spondylolisthesis patient, the posterior arch which we are talking about, it is quite intact, but there is an listhesis if we measure. So this is called degenerative. Next is spondylolysis. What is spondylolysis in short? There is a fracture, there is a lysis has happened, but the listhesis has not. If it lysis occur, then it will call lysis. If there is only lysis, then it will call spondylolysis. Here you can see there will be little bit spondylolysis is there, but you can clearly see the fracture over here. And what do you see in this? Any abnormalities? Neck, if you see the neck is broken. It is looking like collarbone of the dog. So it is called collarbone sign also. This is the neck is the pars, nothing but a pars interarticular where there is a fracture. This is the spondylolysis. Mostly the bilateral it will occur in congenital condition. So I'm not going to detail it. This is again a CT image of the same spondylolysis without any forward shift, any listhesis. So this is called lysis. Unilateral spondylolysis can also occur. And few extra pathologies I have added 1 or 2 slides. What abnormalities you see here?
Querying of low thoracic. Black.
This is quite black. This is air. Air, which is nothing but nitrogen. In degenerative disc disease, you can see in these in X-rays also. We 1 or 2 cases. Yeah. 1 or 2 cases we have also seen here. In MRI also you can see a little bit like black structure. CT also you can see. In case of any degenerative disc disease, this disc is filled by the nitrogen, which is showing very black in the CT. Next is the modic changes. Last class we discussed entirely about these modic changes. The difference only I will show. The modic one way there will be only edema will be there. So edema and fluid is not seen in T1, so it is black. It is white, so it will be in T2, it will be bright. And in modic type 2, what it will happen? Fatty infiltration. Fat will be white in both T1 and T2, so both are white. And in modic type 3, it will become sclerosed. Sclerosed are black in both, so both it will be black. So I wanted to tell you, everyone scan this and it will move to one website. It's nothing but from that website only I have taken a maximum content. I will recommend everyone to read this. These are the sources from where I have taken all the images, and if there is any questions regarding this lecture, you can post in the comments. Thank you so much.